Just want to thank everybody so much today for joining us during your lunch hour. Before we get started, I want to let everybody know that if you have any questions prior or during and throughout this presentation or even afterwards, please feel free to use the Q&A function to ask or the chat to ask your question. I believe we may have some time at the end to have Dr. Day answer some of them for you. And this this session is also going to be recorded, and we'll be sharing the recording afterwards as well. So if you have to jump off for any reason, be sure that you'll be able to get the full presentation as well. But we're thrilled to have Dr. Day here with us, a nationally recognized gastroenterologist and researcher at Fred Hutchinson Cancer Center. Dr. Day's groundbreaking work focuses on improving colorectal cancer prevention through innovative screening methods and quality assurance in colonoscopy. So without further ado, please join me in welcoming Dr. Day. Dr. Day, please take it away.
Fantastic. Thank you. Thank you so much, Sebastian, and to the whole U team for inviting me to speak with you all today. I'm looking forward to telling you about some of our work as well as some of the perhaps useful clinical resources that we have locally here. So the title of the talk is Colorectal Cancer Awareness, Advancing Prevention and Care. My name is Neelendu Dey. I'm a faculty member at Fred Hutch and at UW. No financial disclosures today. A little background on myself. I am from the Midwest originally, did my schooling and training on both coasts, and started my lab here at Fred Hutch in 2017. I've been involved not just in research, but also on the clinical side of things, and including this paper from a few years ago that was a real treat to write and publish with a number of leaders from around the country on a roadmap for the future of colorectal cancer screening in the US. So before we kind of get into some of the nuts and bolts, I wanted to share a couple of resources that we have locally. I imagine a number of you perhaps are tuning in because of either a personal or a family history of colorectal cancer, or for whatever reason, it's sort of on the forefront of your minds. And I wanted to let you know about a resource we have here at the Hutch called the Gastrointestinal Cancer Prevention Program. The GICP, as we call it for short, is a clinic run by two of my colleagues here, Dr. Grady, Dr. Ralyak, who meet in coordination with genetic counselors, medical geneticists, and offer individuals comprehensive advice and recommendations based on their family history, based on any helpful genetic testing and at other labs, as far as creating a personal roadmap of what you should do kind of moving forward when it comes to cancer screening. Another resource that may be of interest to a number of you, we have a robust survivorship program at the Hutch. Now, technically speaking, the word for survivor refers to any individual who's alive at any point after the diagnosis of cancer. So you're diagnosed, you're a survivor from that moment. Colloquially, oftentimes we refer to survivorship or the survivor period as the period after treatment for cancer. But we have resources here and available for anyone in this for whom this would be helpful. So please consider that as well for yourself or your loved ones as needed. All right, so jumping into a bit about colorectal cancer. So just a brief biological background about colorectal carcinogenesis, so the formation of cancer. There is a role of inflammation of our immune responses and of the environment in the development of colorectal cancer. We know that individuals with chronic inflammation, such as individuals with ulcerative colitis, are at increased risk. And it's thought that this cycle of inflammation, healing, and cellular regeneration sort of creates more opportunities as you have this more increased cell division to have things go wrong, to have the introduction of mutations and precancers and cancerous changes. In addition, there are other changes in the immune system that happen with inflammation that can predispose to the formation of cancer. We know that there's an interplay between genetics and modifiable risks, such as the microbiome, which is the focus of my lab, that can affect one's risk for developing colorectal cancer. Interestingly, the majority of individuals who develop colorectal cancer were not born with a genetic predisposition, suggesting that in the vast majority of cases, it's really these modifiable risk factors that one is exposed to throughout life. I'll briefly tell you about what we refer to in the field as the adenoma carcinoma sequence, and then tell you a little bit about how we're thinking about this. So, if we go from left to right, sort of through time, let's say we might start off with, a normal colon. Presumably, there might be some changes through time that may prime you or predispose you to developing precancerous and cancerous changes. We then typically will first develop an adenoma, which is a potentially precancerous growth, colloquially referred to as polyps, that would take some time, typically on the order of years, before that progresses into colorectal cancer. The adenoma or polyp is something we talk about a lot because it's the target of a screening colonoscopy or colonoscopy. We try to identify these lesions and remove them, bringing down the risk, which would normally be, depending on size and what it looks like on the inside when you look under a microscope, the risk of an adenoma becoming colorectal cancer ranges anywhere from about 1% to 50%, depending on some of those features of the polyp. We basically, our practice in this culture, in this country, is to essentially remove these polyps and bring that risk back down to zero. Now, from the research standpoint, we also are thinking a lot about this precancerous sort of primed colon period of time and trying to identify opportunities for early detection and intervention before we get to the cancer stage. We know from colonoscopy that if you detect precancerous lesions and remove them, that brings down the rate of developing cancer. This won't be, a college or a med school lecture, so I'm not going to go into kind of a comprehensive discussion of the genetics and molecular pathways in colorectal cancer, but I did want to tell you about three sort of tidbits that might be pertinent to a number of you in the audience. First, there's a gene called APC that is the most commonly mutated tumor suppressor gene in colorectal cancer. And it's a gene that, as you can tell from the name, being a tumor suppressor, when it's normal in its function, it can suppress the formation of tumors. But when there's a mutation that can render it inactive, an individual is going to be more predisposed to developing polyps and then cancer. There is a condition in which their individuals may inherit a mutation APC called FAP, or familial adenomatous polyposis, in which individuals are more likely to develop polyps and cancer, and the screening recommendations begin earlier in life. So if FAP is something that sounds familiar to you or somebody in your family carries a diagnosis, this would be a reason to meet with either us in our high-risk clinic or your doctor to talk about what the appropriate screening recommendations would be. There's something called Lynch syndrome, in which individuals are similarly predisposed to colorectal cancer and other cancers. And here, the culprit is uh, a, uh, a dysfunction of mismatch repair genes. So through life, externally and internally, cells are going to make errors in their replication. You are going to have mutations, but we have a lot of mechanisms in place to repair those errors. When those mismatch repair genes are not functioning at full capacity, then you're going to be more likely for those mutations to persist and develop and contribute to the development of polyps and cancer. This is referred to sometimes as microsatellite instability, which is, kind of a fun couple of words to say. It sometimes reminds me of, like the Counting Crows album, I think, had a name that was sort of like that. And it's a bit of jargon, but you may hear this as well. And if Lynch syndrome is in your family, this would be a reason to chat with your doctor. And finally, I'll just mention one other gene, KRAS, which is an oncogene, a gene that promotes the development of tumors and cancer, because there's a stool-based test called Cologuard, which looks for a variety of things, including epigenetic changes and a component of blood, but it also looks for mutations in this particular gene. And so, just something to give you a little peek under the hood as far as one of these tests that's out there. So Let's look at the epidemiology next of colorectal cancer. So epidemiology is sort of the science of trying to understand the population level distribution and the causes, the risk factors for developing any disease. And this map shows the incidence of colorectal cancer, this one in females across the world, and the next plot in males. And they mirror each other, slightly higher risks and rates in males. And you can see that CRC or colorectal cancer is a global disease, but it's not evenly sort of spread across the globe. There are some countries, the Americas, Europe, Russia, Australia, that have higher rates. Looking at the US, CRC, or colorectal cancer, is a common cancer uh, in both males and females, one of the top cancers, and it's also a leading cause of death in the US. So um, this is the reason why we talk about it a lot in primary care, in GI, and in society as well. It's a common cancer that disproportionately affects Black Americans, Native Alaskans, and some other minority groups. Now, here is a table from a paper by the American Cancer Society in which they report the lifetime probability of developing on the left side or dying on the right side of colorectal cancer. Well, they talk about multiple cancers. I've just cut and pasted the colorectal cancer bit here, split by sex, and then split by Black and non-Hispanic whites, at least in this table. And looking at non-Hispanic whites already, it's pretty alarming to see that about maybe 1 in 60 or maybe higher non-Hispanic whites will die of colorectal cancer. Even more alarming that approximately 1 in 50 Black Americans will die of colorectal cancer. So there's a public health need for high sensitivity tools for early detection of CRC and precancer or precancerous lesions. So one could argue that we need to cast a net that's both bigger and has a smaller sort of mesh size or smaller holes. I'll just leave this up here for a sec because these numbers are really alarming. 1 in 50, 1 in 60, that's pretty high if you think about the number of individuals who are on this call even, or the number of individuals in your life. Our most common screening tool and sort of the standard of care in this country is colonoscopy. So colonoscopy is a tool through which gastroenterologists such as myself examine the colon using a camera, nowadays a high definition camera, on the end of a thin tube that can be navigated and directed to examine the entire colon and then detect and remove polyps and even early stage cancers. So on the right are some images of a cancer and an aggressive precancerous polyp that I removed. These pictures are probably about a decade old, that I've removed on colonoscopy previously. For many years, up until about 2018, the guidelines had recommended starting colonoscopy at age 50, at least for average risk individuals. And so first, kind of keeping that age 50 in mind, um, this paper looked at the incidence of CRC in the US through time in individuals 50 or over. And as one would expect, if we're targeting this population and we're effectively performing colonoscopy in at least some substantial proportion of individuals, that the incidence would go down through time, and that's what we see. The really alarming thing, finding from this paper was that when they looked at individuals younger than 50, it seemed like there was a more recent uptick in incidence. Now, the y-axis is a smaller number than the previous plot. So overall still, age does correlate with the incidence of colorectal cancer, but these rates had been going up. And from the same paper, when they looked at the incidence rates per 100,000 persons. It's a common sort of denominator in individuals of various age groups by year of diagnosis. They found that going from the top, if you look at individuals greater than 50, you had sort of a decrease in time, which tracks with the fact that there was a 50-year-old kind of threshold. But then younger than 50, over the past several years, decades, there's been an uptick in the incidence. And so this was quite alarming. And so this led to new guidelines that were rolled out over a few years that recommended that screening for average risk individuals be dialed back to age 45. So that's the current recommendation. Note, average risk refers to individuals without a history of colorectal cancer, without a history of polyps or inflammatory bowel disease, and without a family history. So if you have, let's say, a family history, your doctor may recommend that you start screening 10 years prior to the youngest age at which a relative developed colorectal cancer or polyps. When in our endoscopy suite, we've recently started to utilize a new AI technology to enhance detection of polyps. And my boss here, Dr. Hockenberry, gave a nice interview in which he described the technology and how it's been going so far. He was kind enough to mention some of the early discussions that we had about it, in which I, brought up some details pertaining to risk and benefit of AI in general. So we know from machine learning models in the autopilot setting in cars that it can reduce fatigue of the operator. On the other hand, we know from machine learning models in a variety of fields that the models still have a non-zero error rate, and they can manifest biases of the underlying training data. So we really wanted to be careful that whatever we did would benefit all of our patients. And so, after a number of discussions internally and with vendors, we rolled it out, and so far it's been pretty nice tool. We're still studying it, so have yet to kind of publish on our results and findings. Colonoscopy, I'm a believer. I think it is a great tool, but we do need to acknowledge where there's room for improvement. Not all colorectal cancers are resectable, particularly if they're more advanced. And universal access to colonoscopy remains challenging. This is, with healthcare disparities and with heterogeneity in insurance coverage, access to the tests that we would recommend is variable between individuals in society. Even with access, interestingly, not everyone will get colonoscopy. These numbers are increasing with time, but you can imagine that if you grow up in a culture where colonoscopy is not common, or maybe even in this country, several decades ago, it wasn't really something that was talked about as much as it is now. If you hadn't heard about it before, it might sound like a strange proposition when your doctor tells you that this is a test that you need to get. It's pretty unique as a screening test as well, in the fact that it requires typically 1 or 2 days of preparation before you do the test. So, all in all, there have been several observations of barriers, personal, cultural barriers to acceptance and willingness to undergo colonoscopy. And I'll get back to these 2 points in the next few slides. There is also the issue of colorectal cancer potentially arising despite adherence to screening protocols. There's something called interval cancers, which doesn't happen commonly, but where a cancer might develop between colonoscopies. And as we had covered earlier, CRC rates are increasing in younger individuals. When people have options, which we'll get into a little bit, that can improve adherence to screening recommendations. So getting to back to these 2 points about access and acceptance of colonoscopy, I just wanted to highlight some of the work by my colleague, Dr. Asaka here, who established and is the director for the Population Health CRC Screening Program at UW and the Hutch. The mission is to improve CRC screening completion for all UW medicine patients and to evaluate these interventions to increase screening participation equitably for all individuals. The impact to improve patient care quality, increase healthcare equity, and drive additional payer contracts across our health systems. So kind of insurance, that sort of contract. Dr. Saka has shared this slide and the next slide with me. This is sort of how she thinks about community level CRC screening program components. It involves patient navigators, so individuals who really work with patients and individuals to help them understand the healthcare system and how to navigate between points and successfully complete tests such as colonoscopy. And it entails support for primary care clinics by way of education and reaching out and networking. And it includes community outreach and engagement, and that might entail events where there are tables of experts and oftentimes CRC survivors who are available to talk to anybody walking by who might want to talk about CRC. It might involve one of those blow up kind of colons with polyps that people can walk through and start to understand CRC. Dr. Asaka was kind enough to invite me to an event that she had organized at a church, which was a lot of fun. So we're getting a question about why is it that CRC is more prevalent in younger individuals now, and that is a really exciting research question that we don't have a clear answer to. Um, the the thought is that over the span of just a few decades, it's unlikely that our genetics have changed. So what could have changed? And one of those things that might have changed could be the microbiome, diet, the way we prepare and process foods. And so there is a lot of interest because of that logic in the kind of the research space where I'm operating. I agree with Greta. Interpreters are very important too, absolutely. Um, and I know that that's part of the population health program, and I would imagine that would probably fall under all three of these bars here. Thank you, Greta. And then should guidelines be updated to screen at much younger ages? Now that's a very interesting question. Um, we, we picked 50 initially. I think we probably all have some sort of numerical bias towards base 10 numbers and then and multiples of 5. But the reality is that if you were to do a calculation of an individual's precise risk for each of the nearly 100 people in this call, we'd probably have a slightly different recommended age if we had all the data and if we could calculate our risk. We don't have all the data, and so these are numbers that are best guesses based on population level studies. Should it be younger? One of my research sort of ideas is that I think down the line, probably we would want to have some sort of risk assessment, some sort of non-invasive screening test, perhaps as early as even in a pediatric clinic. It remains to be, that's purely speculative, by the way, but it remains to be seen whether that would be helpful. All I can say is from looking at the microbiome and looking at CRC associated microbes that you can see some of these CRC associated microbial features even in kids' microbiome. So I don't know what what that means or who exactly would need to be targeted, but I think there is a potential role down the line to think more broadly about the kind of the timeline of when we want to really think about this. Great. And yes, exactly. Thank you. The recommended starting age was reduced to 45 just a few years ago. And that was between 2018 and 2021. There were a couple of different societies that sort of rolled out the age. So now the number to remember is age 45 for average risk, but earlier if you have family history or other risk factors. Thank you. From Dr. Asaka's team, they've shown that CRC screening rates have been able to be increased through some of the measures that they've implemented through across races and through time here. Another plot that she shared with me. And this has been captured in the 2024 Washington Health Alliance report, which scores the UW Medical Center, which includes Fred Hutch. Their screening rates is quite good compared to the national 90th percentile and compared to the state average. So, one more Met chat. Let me just see here. For those that are in the high risk, in addition to having a regular colonoscopy, is there anything additional a person can do to reduce risk? I've been told to take an aspirin and then not to at the time premenopause, lose weight, and then told no direct correlation. Where's the research heading? Aspirin is pretty well established as reducing risk of developing polyps and cancer, but there are risks that must be considered as well for an individual. So aspirin, NSAIDs can increase the risk for GI bleeding, for example. And so depending on other health considerations, there may or may not be a recommendation. Obesity is associated with many cancers, including colorectal cancer, but the effect size is modest. And so the recommendation that there is almost certainly a benefit, but it's not like let's say with smoking and lung cancer, it was like 33-fold or increased risk or more or less, something along those lines. I'm not a lung cancer expert. That's what I can sort of recall. But whereas with obesity and colorectal cancer, something like a 1.2, increased effect size. So it's a little bit more modest, but almost certainly helpful. Good. And then let's see if you're at average risk, what is the recommended first screening? Yeah, so that's going to be 45 and Cologuard or colonoscopy. Let me get back to that. We'll go over some stool-based testing options. And then how often is colon cancer found on the outside of the colon? Okay, so colorectal cancer develops from the cells lining the colon. So that would be a different kind of cancer if it's along the outside of the colon. And generally, those cells outside the colon don't primarily sort of develop, into cancers and whatnot. And follow up after polyps and 3. Okay, so let me get back to those last 2 then as well. All right, so then we were just talking about a couple slides ago about the potential sort of challenges with colonoscopy alone and the fact that additional prevention tools are needed. Options can improve adherence. We know that there are some tests, non-invasive tests that an individual might be more likely to undergo than invasive colonoscopy, particularly if they're unfamiliar with the test. So here are some established stool-based testing options. So there's something called FIT, fecal immunochemical test, that uses antibodies to detect hemoglobin, which is a component of blood. Generally, it's performed annually, and the sensitivity for CRC detection is about 80%. That's good, but if what that means is if 5 individuals with CRC do the test, one of them will have a false negative result. So that's also scary. Then when you look at the sensitivity for detecting high-risk polyps, much lower at about 30%, and for average risk polyps, about 7%. Cologuard uses several DNA markers from the shed colonic cells combined with FIT testing. And this is performed, every 1 to 3 years. It kind of, if it's negative, you might be told to come back in 3 years. On one stool sample, the patient mails an entire bowel movement. The sensitivity for CRC, is reported at about 92%, but the sensitivity for the precancerous lesions is much lower. So for the highest risk, maybe about 42%, and much lower for average risk. With abnormal findings on any test other than colonoscopy, the recommendation will be to get a colonoscopy. So that's the other thing to consider. I think there was a question of should I get Cologuard or colonoscopy or not. There may be some insurance reasons to consider one or the other. I know I've seen the situation. I think this has been resolved, but where an insurance company will pay for one screening test, and so they paid for the Cologuard. It was positive, but then the insurance company was like, "All right, we're done. We paid for the test," and then they were kind of left with needing a colonoscopy, but at least initially, I think that they didn't have coverage for that colonoscopy. So it may depend, maybe something to look into with your individual insurance company as well. The U.S. Multi-Society Task Force a few years ago sort of published this tier system, their tier-based recommendation of the different screening tests. Colonoscopy, and here it's split into invasive and non-invasive. Colonoscopy is the standard in this country. If you have a negative colonoscopy, you'd be asked to come back in 10 years. So this is kind of the minimum. If you had anything of concern, you may be asked to come back in 1, 3, 5 years, something like that. And FIT test is also considered tier 1, but because of those test characteristics where cancers and polyps can be missed, you can't go that long. You could go maybe a year at most between them. There's something called virtual colonoscopy, which is a CT scan that could be done every 5 years. It's under this invasive category because you do the bowel prep and then also you have gas insufflation. So gas is introduced into the rectum, into the colon to distend the colon so that the CT scan gets good images. You can do a sort of a shorter version of a colonoscopy that is often done at Kaiser. Sigmoidoscopy that might be done every 5 to 10 years. Cologuard is considered tier 2. And then tier 3, generally, nobody's going to recommend a capsule study, which is where you swallow that pill that has a camera to do screening. There's a famous quote from Dr. Sydney Winowar: "The best test is the one that gets done and done well." So that's important to keep in mind also. So if you're hesitant to get to colonoscopy, but you're willing to do either FIT or Cologuard, I would do that still. I mean, it's better to get something done and get the information, and then at least have some information to act upon. I'll also tell you about, let's see, we have another comment here. Yeah, with the insurance, that's right. And there is a new Cologuard being released. Um, okay, so let's see. Is there any advantage for someone that is in a 3-year return who has an adenoma to get or CRC to get a Cologuard in between? Generally not. Generally, once you're on that track of you have some risk, you have something to look at, you're kind of on the colonoscopy track. The Cologuard is really intended as sort of a gateway, kind of an an intro type of test. Let's see. Colonoscopy in 2022, 10 millimeter adenoma removed, come back in another 3 years, wondering if no polyps are found, if they were stretched. Yeah, they probably would. If it was a clean colonoscopy in this next one, they probably will stretch it. And then this assumes that the prep is really good and they got a really good look. There's a possibility it'll stretch to 5 years, but there's a little bit of room for leeway on the actual recommendation. Two of my colleagues, whom I introduced earlier, Drs. Asaka and Grady, had a big paper in one of our major medical journals a year ago, the New England Journal of Medicine, reporting on a blood-based test for CRC screening. And the idea, so this is called cell-free DNA blood-based test. And the idea is you could take a blood sample from an individual, and characterize mutations known to be present in CRC, look at epigenetic or epigenomic modifications. So these are modifications that affect whether a gene is made into a protein or not. So they can look at DNA methylation and DNA fragment size, and they can integrate these signals to produce an actionable result. Abnormal signal, normal signal. They reported this in a variety of ways, but here's one of the tables from that New England Journal paper. So the sensitivity, meaning what percentage of individuals with colorectal cancer will be told they have a positive result, is pretty decent, about 83%. And the thing to note is that the data suggests that individuals are more likely to get a blood-based test than a stool-based test. So kind of going back to Dr. Winowar's quote, if you're more likely to get this and you're not going to get the FIT or Cologuard anyway, I mean, you want to just get whatever test you're willing to do, as long as that test can be done well. Kind of along the lines of what we were talking about, the deficits with detecting precancerous lesions. Similarly, this blood-based test has a sensitivity of about 13% for advanced polyps, the high risk polyps. So not as good as we would like, but very good if you have cancer, pretty good at detecting that you have cancer. All right, so now just to shift a little bit to the gut microbiome, the area of research of my lab, I just want to give you a few bullet points and then tell you briefly about one of the papers we recently published. So the microbiome may be a driver of carcinogenesis, so the development of cancer. There are some key bacterial species that have been identified, and that's much more than just this list of 3. But there's some variability as well. So for example, each of these 3 seem to have a high correlation with colorectal cancer, but they're not seen in all individuals with colorectal cancer, and they're also seen in some individuals without colorectal cancer. So this is still being kind of worked out. There are some mechanistic contributions to tumorigenesis that are starting to be appreciated. There's indirect evidence that the microbiome can impact colorectal cancer formation through a couple studies that looked at the impact of early life antibiotic exposure, which appears to be correlated with an increased risk of CRC later in life. This is pretty wild. So in the first couple of years, you get antibiotics, increase risk of CRC later in life, presumably some shifts in microbes and the subsequent immune education, so what the immune system is seeing. It's not at the level where it would affect one's screening recommendations, but it is I think the significance was such that we believe that the microbiome is a player. There are preclinical data, which means animal models that have demonstrated that gut microbiota influence the formation of tumors. And the way that the bacteria may have these effects may entail molecules or metabolites that they produce, and several of them are listed here. There are some challenges in these interventions. The microbiomes vary from person to person. They're very complex. They're communities and networks, so it's very difficult to just take out one bacteria or add one bacteria. There are studies showing that if you take probiotics, generally you can't rely on those probiotics colonizing. Maybe in a subset of individuals, they will sort of set foot and stay, but generally that's not a reliable kind of feature of probiotics. Now, the future of microbiome-based strategy may involve next-generation probiotics, personal dietary interventions. There's something called fecal microbiota transplantation, but probably what will happen is a more sort of a designer-type probiotic consortium, and microbiome-based biomarkers and sort of the risk stratification and treatment of individuals. I'll tell you about one study that we published a few months ago. It was called Colorectal Cancer-Associated Bacteria Are Broadly Distributed in Global Microbiomes and Drivers of Precancerous Change. I'm just going to take you through three features of this paper. One was we used sort of a novel approach for looking at sequencing data. So one of the ways that one can study the microbiome is by taking a fecal sample, extracting the DNA, and sequencing the DNA, and then you can get an idea of what kinds of bacteria are there and what they're doing. How you exactly put all those sequencing data together can vary, and there have been different methods developed. We developed an approach that gave us an insight into groups of bacterial strains that may be correlated with cancer or health. We felt there were computational and statistical advantages, and we also felt like it allowed us to really focus on the disease. So the traditional way would be, let's just look at the microbiome sequencing data. Let's see what each sequencing read is closest to in a reference database. Let's construct a table of what percentage of bacteria A, B, and C there are. And then after all that, then let's relate it to the colorectal cancer. But our approach was sort of more CRC centric, and then seeing what clusters of genes really tracked with it. It was inspired by some other researchers, and it was actually, interestingly, also inspired by Spotify. The first algorithm that we used was actually the Spotify algorithm on GitHub. It's called Annoy. Proximus nearest neighbor is the kind of methodology, and so they call it Annoy. But we actually later changed it and developed our own protocol. So I'm going to show you a sort of a complicated figure, but I'm going to give you, just for fun, but I'm going to give you a little bit of an intro before I show you the figure. So you'll see a series of rows that are like this, and they'll all be different strains or types of a species called B. obium. The columns each refer to different genes that are present across the different strains of B. obium. And if there's a white space, it means it's not present in that strain. If there's a colored space, it means it is present. And the color coding refers to how strongly correlated it is with CRC. So red means it's more strongly correlated. The blue means it's correlated with health. So here's the same figure I showed you. And then here's a set of 57 strains, all of the same species. And this is just, example. So these are each different strains, slight variations of the same species. And I'm showing here a subset of the genes found across all the strains. Excuse me. There are 5 groups of genes, sort of blocks of genes. We call them CAGs, or co-associated genes, and they each had slightly different correlations with CRC. They were generally health associated here. Some were very weakly associated, but some were strongly associated with health. And so depending on which flavor you might have of a bacterium, you might have different health effects. Now, when we looked across not just this one species, but all 354 species, so there are 354 vertical lines here, each representing different species, and the y-axis shows that correlation to CRC on the top or health on the bottom. We saw that many of these species actually had a wide span of their association, such that you couldn't really say that, oh, you have species X, and therefore you're at high risk. It's more like you need to understand a little bit more about that species to make that claim. This x-axis of y equals 0 indicates sort of the middle line between being CRC associated and health associated. So a number of these span on both sides. There's one bacterium, F. prausnitzii, that was kind of interesting because there had been a literature building about it being health associated, particularly in Crohn's disease. But then there have been some other reports that maybe it's not so simple. And here we found that there really is a wide spanning range depending on what flavor of F. prausnitzii you have as far as whether it was cancer or health associated. Okay, so that's the first thing I want to tell you, that there's probably within a species there can be varying different flavors with varying associations of cancer health. The second thing I want to tell you about this paper is that it appeared that there may be different ecosystems, so kind of birds of a feather flocking together. It seemed like CAGs that were CRC associated were typically not found in systems where there were a lot of health associated CAGs. Um, this is a plot showing kind of how correlated, how often one CAG appears with another, showing the top 10 cancer-associated CAGs and the top 10 health-associated CAGs. And the only line spanning this is this really faint line from here to here. But generally, they're kind of different ecosystems. On the bottom left is a histogram showing the correlations between CRC and CAGs and CRC CAGs. So, decently high. Health associated CAGs, decently high. But between CRC CAGs and health CAGs, it's inversely correlated. So that's the second thing. There may be discrete ecosystems, maybe not as simple as one particular kind of strain. The third thing I want to tell you is that we found that the microbiome is related to a type of precancerous change called senescence. Senescence may have varying roles in development, healing, and aging, but there is something called a senescence-associated secretory phenotype. When there's enough inflammation over a longer period of time, a cell sort of gets burnt out and angry, and it's actually, this kind of cell has been referred to in the lay press as zombie cells. In fact, I was watching this show on Disney Plus with my kids a couple years ago called Limitless with Chris Hemsworth, and they talked about, and he went through a variety of experiences that were revolved around health promotion, and they talked about zombie cells in one of the episodes, actually. And I remember this project was just starting to come to fruition. I was pretty excited. But there are some challenges in defining and quantifying it. So in this particular slide, what we did was we looked at cells in the colon at a single cell level, and then tried to understand to what extent it was acting like a senescent cell or not. I've labeled here a few different types of cell populations. If you're blue here, that's the senescence-associated secretory phenotypes. Those are your zombie cells, and the red is sort of everything else. And you see a lot of the blue, the zombie cells, really in a few discrete cell populations. And these same scores are just shown here as distributions and histograms. These cells being neutrophils, stromal cells, which include fibroblasts, and macrophages. We thought we looked in the literature to see if anybody had really talked about this. We found one paper where they had reported two particular Porphyromonas species, two strains, or two species belonging to this one genus that were associated with senescence. So we thought maybe our results were more of a generalizability of this report looking at this very specific two species. We also found a paper showing that medicines that inhibit senescence, called senolytics, can reduce colonic tumorigenesis and increase lifespan in a mouse model. And so the thought goes, well, maybe could this be an opportunity to target precancer and microbiome-induced precancer state. So before we go to questions, conclusions for the talk here today, find the right CRC screening option for you and your loved ones and get screened. There is a public health need for ongoing research and interdisciplinary collaboration in this space. I don't have to tell this audience the value of NIH funding. Although one thing that you may not know, even from a pure economics perspective, even if you didn't care about the science or the medicine, the return on investment for NIH dollars is tremendous. In general, every $1 brings back or generates $2.50 across the board, across all research. And then when you look at particular areas like genomics and CRISPR, it's much higher. So even from a financial perspective, and this is detailed in many economist articles and stuff, in non-scientific literature as well, NIH funding is a really good thing. And then finally, the microbiome may offer opportunities to develop new clinical tools for preventing CRC. So with that, I'll just thank the organizers again for inviting me. A picture of some lab members, past and present, and some collaborators on this, some of our NIH funding. And we just got a question that came in. Let me just see here. All right, so thank you for this talk. Barrier is that the instruments are not only disinfected, not sterilized. And additionally, there's disinfection solution if not properly flushed. Why is there not progress? Single-use instruments and creating instruments that can be sterilized. Got it. Yeah. Um, this issue of sterilization is an important one. Certainly, there have been reports when scopes haven't been sterilized of transmission. Generally, the process that these scopes go through, we're targeting sterilization. Um, uh, and so if it's been satisfactorily uh, uh, cleaned, then the expectation is that there's not going to be a transmission of anything. And generally, the instruments and the cleaners are designed and the processes are designed in such a way that we believe we can achieve this. This was an area of controversy a few years ago when there were a couple cases at I believe UCLA that really generate a lot of discussion and changes nationwide. There are actually single-use instruments as well. There are, and in some cases, those are very appropriate. But there are also environmental concerns for doing single use for every single procedure as well. Not that cleaning chemicals don't have some concerns as well, but there's a risk-benefit discussion there. Great. Well, thank you for the other comments as well, and thank you to everyone for tuning in. Happy to take any questions on the chat, or if anyone wants to unmute. Thank you.
Thank you, Dr. Day. I think Sarah just had that one question just now as far as talking about diet as part of prevention.
Oh yeah, great. Yeah. Diet as part of prevention, it's an interesting area, and I think that we will have more to say on it as we better understand the microbiome. Um, if all of us on this call were to have the same meal, we would have different physiologic, immunologic, microbial responses, and for that reason, it's a little bit challenging. There's there's a story from the heart disease field, microbiome field, that may be pertinent here. So with heart disease, there had been over the years sort of varying recommendations on what you do with red meat. Is it bad, is it good? And then about a decade ago, there was a researcher from Cleveland Clinic, Stanley Hazen, Hazen, if anyone wants to look up his work, whose group looked at individuals undergoing cardiac catheterization, and they collected. So that's the kind of test where you look at the blood vessels around the heart, and you characterize the extent to which there's atherosclerosis, and you can do things about it if there is. And they collected serum samples, and they looked at these individuals through time. They then stratified the individuals who developed, let's say, heart attack, or the individuals who stayed healthy, and they looked to see what's different in their serum samples. And one of the one molecule they identified that was the most sort of strongly predictive of atherosclerosis was this molecule called TMAO. And it's a molecule that's generated from a dietary component, phosphatidylcholine, and found in eggs and meat, that first is processed by microbes and then the liver, and then once it's enters circulation, it can really promote atherosclerosis. They then did a series of follow-up studies, including looking at individuals with or without the bacteria that could do this conversion, and feeding them these individual ingredient to see if they get a spike in the serum concentration of TMAO. They even recruited vegans who were willing to consume a beef capsule for the study, and they, based on what their microbes looked like, they were able to demonstrate that there was a spike or not in this particular molecule. And so, after these papers started coming out, it sort of brought a lot of clarity, or some clarity. I mean, it's hard to go back and really, we didn't have fecal samples from those previous studies decades ago, but it brought some possible clarity to the mixed sort of results of the red meat heart disease literature. Perhaps it has to do with whether you have that microbe that can make that conversion or not. So anyway, that's kind of a long-winded answer to say that I don't have a clear answer quite yet. Certainly, we do know that there's a modest effect of plant-based diets when it comes to colorectal cancer, and that there are a number of groups really interested as well. And we're starting to put together a portfolio that, of avoiding things like sugar-free products, processed foods, may have beneficial effects as well. All right, so after my long-winded answer, got a number of other questions roll in. Sorry about that. So from a cultural point of view, it's been difficult to convince my community African to go for screening as not a mainstream test. How can one encourage more screening? That is very difficult. My parents are from Bangladesh, and when I was a GI fellow, meaning a trainee, when my dad turned 50, and or maybe I was a resident then, but it was somewhere around that time, and I knew I was going to GI in any case, and I was like, Dad, you got to get your screening, you got to get your colonoscopy, you got to, do something. And he just would not get it done. Every time I'd come home, I'd see maybe, some like fit kit he got from his doctor, maybe they're doing Guayax, and I can't remember. And then, and he just wouldn't get it done till he was 60. And I was like so embarrassed. I was like, oh my God, like I can't be, my own dad, I can't even get him to get a colonoscopy. But there is a real, when it's not something that people talk about openly, when it's not something that you've heard about, it really does seem strange. So I think the main thing we can do is just talk about it, really, and sort of remove the stigma. I think across American society, it's happening more. It's more in movies and shows. It's just discussed more openly, but certainly in communities, Bangladeshi communities, the African community, I think probably could be discussed even more. All right, sorry, I'm talking way too long. So, should someone in their 20s who is diagnosed with metastatic colon cancer with no family history, the fact to have their children genetically tested? Yeah, so that's definitely a good question that should be discussed with oncologists when there are tumor samples or tissue samples. They can do the genetic testing. They may want to, depending on what the genetics are, they may want to test other family members for sure. Are you aware of another place UW Medicine is opening at Northwest Outpatient Medical Center for colonoscopy procedure? I don't know for sure about all the endoscopy centers, but for sure Northwest Hospital, as was mentioned here, Harborview, Montlake, the Hutch, uh, the whole system. We're those are all places you would be welcome to come get your colonoscopy. Thank you for the thank yous. If a colon has been fully removed, is CRC still a concern? No, but you have to think about where if there could be any colonic tissue anywhere. So there's, for example, a situation where people who have esophageal cancer might have their whole esophagus removed, and maybe a part of the colon gets put up here for the physiologic benefits. Well, you actually have to do colon cancer screening up here in that case. So if it's been fully removed, no, you don't. It's not a concern. But you have to think broadly. Just because a piece of colon's been moved up here or whatnot doesn't mean the risk is gone. Is there any data on GLP-1 medications and change in microbiome? Yeah, that's almost certainly a thing. It's sort of emerging, but there are effects on gut motility. It sort of slows things down that will impact the microbiome. And there are also, going the other way as far as microbial effects on the GLP-1 axis. There are some data as well. So as far as the GLP-1 medications and change in microbiome, I think look out for emerging studies that really describe this in detail. It's just sort of starting to be understood now. You mentioned senolytics as potentially preventing CRC. Is that something that's found in certain foods? That's a good question. I don't know exactly, but I wouldn't be surprised if there's a variation between different diet ingredients that affect that process in general. I just don't have a precise answer for you on that. Sorry if I missed this, but when should we start screening since there's sometimes say waiting till 45 is too late sometimes. Yeah. So for average risk, right now it is 45, but if you have any concern at all, you would want to talk to your doctor or, and I'll just pull up the slide from the beginning. We have, whoops, we have a high-risk clinic at the Hutch here. where you can, if there's any concern, you can come meet with one of my colleagues, medical geneticists, and kind of get your own personalized recommendation. So if for whatever reason you think maybe 45 isn't the right number for you, you're a little more concerned, just come chat with us or another provider. And thank you again for all the thank yous. Great. Well, I think that's all the questions then.